Milestones in Algology, where the correct meaning of the word algology is the study of pain, from the Greek words algos, meaning pain, and logos, meaning the study of, is a collection of educational material distilled from many clinical and basic science studies, as well as clinical experience. Therefore, it can also be viewed as a selected, limited historical overview of the evolution of this medical specialty. The intent of these milestones is to provide simple, basic, easy to understand concept related to this medical discipline, since knowledge that is barely divulged and poorly understood is narrowly applied, and the advancement of the discipline to which it pertains is greatly hindered. In an attempt to make this basic concept of pain medicine easier to be understood by the majority of the people who are not expert in the field, many of the details, especially those related to basic pain research, have been omitted, and the concept that have been greatly simplified. This milestone must be considered as a starting point. More detailed information can be obtained from textbooks and specialized research articles related to this medical discipline. The milestones have been divided in several modules. The first 5 modules of Milestones in Algology will illustrate the following topics. Module number 1 will present concepts related to the physiology and the pathophysiology of pain. Module number 2 discusses the incidence and deleterious effect of both acute and chronic pain, as well as introducing clinical and basic science research that strongly support the need of personalized pain therapy. Module number 3 focuses on myth, biases, misconceptions, as well as reflecting on some logical consideration. Module number 4 will discuss the major barrier to the advancement of this medical specialty, which are pain assessment, pain education, and pain research. And module number 5 will discuss some ethical considerations related to this present treatment of pain, as well as describing the concept of torture by omission. The title of this first module, which has been divided for clarity in 2 separate chapters, is The 2 Phases of Pain. In chapter number 1, I will explain how, under normal conditions, pain is the physiological experience of the activations of the nociceptive system, a protective, warning, high-threshold neural vital function. In the chapter that follows, it will be explained how this nociceptive system, due to trauma, not only physical, but maybe even severe emotional trauma, illness, and toxicity, can change and become a malefic neurologic disease, which triggers the disabling pathological pain experience. Before I begin, however, I am reminded by a statement of Aristotle of 23 centuries ago. The search for the truth is in one way hard and in another way easy, for it is evident that no one of us can ever master it fully or miss it wholly. Each one of us adds a little to our knowledge of nature, and from all the fact assembles arises a certain grandeur. Therefore, it is clear that some current concept described in these milestones will need to be changed due to new research findings. The importance of research and new findings, including the ones that we now cannot even imagine, was emphasized by Dr. Andrew von Oschenbach when, in 2003, then the director of the National Cancer Institute, gave a lecture at The Ohio State University entitled Palliative Care as Cancer Intervention, Progress with a Purpose, and said,
It's important in this area to constantly remind ourselves that we must know what we know. We must know what we don't know. But it's also important to know that there are things we don't know. Be open to mystery and to be open to discovery. I show you this picture because I'm very fond of it as a reminder to myself of how I must constantly be open to realizing there are things I don't know, that I don't know. And when I ask most people to tell me what they think this picture is, there are some, actually many, who tell me that it looks like a rose window, and I recognize this is not projecting very well, but that's actually the rose window that's in the west wing of the National Cathedral in Washington, D.C., and the name of that rose window is Creation. And people will recognize there's a little bit of similarity. Well, this is not a rose window. This was on the picture of Science magazine over a decade ago, and what it is a picture or a computer rendition of the DNA helix, but instead of looking at it as we normally do as a twisted ladder, this is a picture looking down the center of the helix. It's interesting that embedded in our genes is an image that people have had emotional investment in for centuries. What's even more interesting to me is I confessed that I began my career as a physicist interested in computer sciences, but as a physicist, this has the appearance to me of an induction coil. And wouldn't it be interesting if in the structure of our genes, where we in Western medicine have often thought of the biologic basis of life being chemical energy, that there was a mechanism and a process for electromagnetic energy. And if that was the case, then many of the issues that are relevant in Eastern medicine, like chi or life force or vitality, many of the things that we think about today as complementary medicine having to do with the role of massage, the role of relaxation, the importance of symptomatic care that includes meditation, may in fact have a very profound and very important biologic basis.
Sometimes many concepts that a person has in an unconnected and nebulous fashion become connected and in clear focus by listening to a magisterial lecture. This happened to me in 2009 when I attended the main lecture of the yearly meeting of the American Pain Society. The lecture was given by Tony Ashe. Tony Ashe is professor of anesthesiology and pharmacology at the University of California in San Diego, and a pioneer in pain research. In the mid-1970s, he developed an animal model that allowed the infusions of substances around the spinal cords of rats. Using this model, he was able to test, among other substances, the effect of opioids. And if we now use intraspinal opioids, either in the epidural or the subarachnoid space, it is mostly due to his basic research. Tony Ashe's presentation was titled Principles of Pain Processing Suggested by the Journey from Single Cells to Humans. In other words, approach or avoid. This is Tony Ashe in a short segment of his presentation.
Easy to demonstrate in just a drop of pond water that these paramecia will approach and they will avoid. They have that ability. Interesting, because there are a variety of stimuli that the paramecia will be attracted to. Things like acetate, glutamate, lactate, things that are oftentimes associated with nutrients. And there are some products that repel it, lysozymes or GTP, some other things that have been demonstrated. Now that's within the cell. Now let's go up to a more complicated animal, like, for example, this Tritonius diomedea. Now the Tritonius diomedea, this is a sea slug, and it has the ability to recognize food. And what you see here is this Tritonius approaching a sea pin, and it's touching the sea pin. Remember, it's a touch. But it stays with it because it recognizes from the chemical constituencies that it senses in its buccal pouch the fact that this is food. And so who's for lunch? Well, it turns out it's the sea pin that's for lunch. And the sea pin will respond, and you can see the damage that has been put there. Okay? Now, it turns out that by the same token, that sea slug, as you can imagine, has the ability to stay away from bad things, or at least to avoid bad things. So in this case, this particular Pycnopodia, which is a starfish, whose favorite meal is in fact the Tritonia, is now approaching our friendly little Tritonia on the right there. And you can see that there's a reaction. And the reaction is this backward flip that causes the Tritonius to jump and be moved away. And in a normal environment, there would be sea currents that would cause the Tritonius to be actually drifted further away. But you can see that it doesn't really like its friend, the Pycnopodia there.
Tony Ashe continues his lecture and explains how this ability to avoid damaging things develops in higher animals and humans as the very complex nociceptive system. The nociceptive system must be recognized to be a vital function because its absence is not compatible, as I will explain later, with long life expectancy. Let us first consider the definition of pain. A panel of experts convened by the International Association for the Study of Pain in 1978 defined pain as a sensory and emotional experience associated with actual or potential tissue damage and described in terms of such damage. Neurophysiological studies have demonstrated wide neural connections between the nociceptive pathways with the sensory cerebral cortex and the frontal brain lobes associated with emotional responses. The question arises, why does a physical sensation need an emotional response? This became clear to me in the late 70s when I saw a patient that had been lobotomized. In the late 50s and early 60s, some patients with intractable pain were subjected to a lobotomy, a surgical procedure which consisted in detaching the frontal lobe from the rest of the brain so that the emotional component of pain was removed. This patient that I saw in the clinic was extremely interesting. I asked him if he had any pain, and his answer was, yes, I have a lot of pain. I have severe pain. But at my next questions, how much does this pain bother you? His answer was, no, this pain does not bother me at all. The problem with this situation was that this individual had an abnormal behavior. He was poorly kept, he did not exhibit any emotion, and if needed, he would urinate or defecate on the floor. Clearly, this was not a proper therapy for severe intractable pain. The possible explanations that a physical sensation needs a strong emotional connection is that if we consider the physiologic functions of pain, which is a protective vital function, then it needs to be effective, to be associated with a fast, strong response. That is only possible when emotions are involved. This very simple slide introduces the basic physiological concept of the nociceptive system. The word nociception is derived from the Latin words nocere, which means to harm or to cause damage. You can therefore appreciate that under physiological condition, this system responds only to high-intensity, potentially damaging stimuli. It is therefore a protective mechanism, a protective vital function. This extremely simplified drawing describes several important basic points of the nociceptive system. The peripheral nociceptors are free nerve endings that, under normal conditions, are activated by strong stimuli. The stimuli generate impulses or action potentials that are transmitted by the peripheral nerves to the spinal cord. From the spinal cord, via the spinothalamic tracts, they reach the thalamus, and from the thalamus to the sensory cortex and the frontal cerebral lobes. It is important to appreciate that as the impulses or action potential travel from the periphery to the thalamus, they generate what have been called segmental and suprasegmental reflexes. They include vasoconstrictions, muscular spasms, release of catecholamines, and therefore hypertensions and tachycardia. Another very important point to be appreciated is that pain is a cortical experience, and therefore only conscious patients can experience pain. Unconscious patients experience nociceptions, mostly in the form of tachycardia and hypertension, maybe muscular spasm, but they do not perceive pain per se. The other important point that has to be explained is that the peripheral impulses traveling in the nervous system can be modulated. In other words, they can be altered. This alteration can be both in the form of facilitations or augmentations, or on the contrary, can be minimized. As an example, if a young individual has to receive an injection, by focusing on the expectations of the event, most likely the painful experience will be more bothersome than the actual pain caused by a fine, sharp needle. On the contrary, if the same individual is captivated by an interest in competitions, the pain associated with the minor injury may not be noticed until after the end of the game. We can therefore appreciate that the modulation of pain can work in either augmenting or minimizing the perceptions of pain. This phenomenon of neuromodulation of pain was clearly described by Henry Beecher, one of the founding fathers of American anesthesiology and a pioneer in pain research. In 1944, he was a medical officer with the United States Army that landed in Anzio, Italy. Many soldiers were wounded, both during the landing and the resulting battles. At Anzio, he made several important observations. He noted, for instance, that most American soldiers that had been wounded, even seriously, did not complain of significant pain, even though they were awake, alert, and not in shock. They were mostly elated because for them the war had ended and they would return home. However, he further noted that later in the hospitalizations, they reported pain caused even by a simple injection. Beecher hypothesized that the initial realizations of the soldier of still being alive after being seriously wounded, and the fact that he would return home, caused a psychological state that decreased the perception of pain. 20 years later, Melsack and Wall studied different modulations of painful stimuli. They were fascinated by the recurrent observations that when a person gets hurt, one of the first response is to rub the area where the pain is perceived. They studied this phenomenon in the laboratory and found that the larger and faster nerve fibers, the 8-beta, that carry the sensations of rubbing or proprioceptions, were able to interfere at the spinal cord level with the transmissions of nociceptive impulses carried by the smaller and slower A delta and C fibers. They called this phenomenon the gate control theory, and the article was published in the prestigious journal Science in 1965. The concept of this theory is depicted in this Australian rendering done in commemorations of the 25th anniversary of the proposal of the theory. We see the kangaroos representing the impulses carried by the large, fast nerve fibers that close the gate to prevent the passage of the slow impulses represented by the alligators. This seminal study had the effect of greatly stimulating basic science research in the field of pain, which up to that point had been mostly neglected. Fernando Cervera is a professor at the McGill University in Montreal, Canada, and a leading pain researcher. In 2008, he was awarded the John Bonica Lectureship by the Regional Anesthesia and Pain Medicine Society. The title of his presentation was Pain, Friend or Foe, a Neurologic Perspective. In his presentations, he divided the perception of pain in 3 different phases. Phase number 1, depicted in this slide, is the warning protective mechanism, which is the physiological functions of pain. You can see in this drawing that a strong but brief stimulus activates a high threshold peripheral nociceptor, which generate impulses that are carried by the nervous system to the cerebral sensory cortex, generating the perceptions of pain for the individual. This basic concept is not new. In the 16th century, Descartes described this same protective mechanism but in simpler terms. The vignette on the left, which has been frequently reproduced, depicts the basic neurologic protective function. Here we see a child whose foot is getting close to a fire. The heat causes the generation of a message. The message is sent to the brain in the form of a ringing bell that tells the child to move the foot away from the fire to prevent further damage. Therefore, the perception of pain generated by high-intensity stimuli is a basic protective mechanism. There are a few reports in the medical literature of children born without the sensation of pain, and these children die quite young due to the multiple unperceived injuries or infections. This clearly underscores the concept that physiological pain is a protective vital function. There is an interesting disease which has been the scourge of humanity for thousands of years. The disease is leprosy. About 150 years ago, it was found that in the advanced stage of the disease, the bacillus of leprosy destroys both the superficial proprioceptive and nociceptive fibers. Therefore, these patients, because of these conditions, are not aware when they get injured or when an infection causes tissue destructions, which leads to the awful lesions associated with this disease. Dr. Brand, in his book entitled Pain, the Gift That Nobody Wants, describes his experience as a missionary physician in a leprosy hospital in India. He reports that sometimes, in the morning, they found that some patients had their area of the nose and earlobes that were bleeding, and could not figure out the reason for these findings. They had one person to stay awake all night. What transpired was that rats would come out at night and bited the nose and earlobes of the patients, who, because of lack of sensations, would not react to the injury and would notice the lesion only upon awakening the next morning. The description of this event explained the title of Dr. Brand's book, Pain, the Gift That Nobody Wants, because in normal physiological condition, pain is a warning, a time life-saving signal. For instance, cancer would be much easier to treat if, at its earliest onset, would be associated with pain that compels the patient to seek prompt medical attention, instead of being a silent disease until its advanced stages. Chapter number 2 will explain how this nociceptive system, due to trauma, not only physical, but maybe even severe emotional trauma, illnesses, and toxicity, can change and become a malefic neurologic disease, which triggers a disabling, consuming, pathological pain experience.